Now, a new approach is called N of 1 studies. And that's where you take one person and you do randomization on what they receive. Okay, now I'll step through this a little bit more to make it more clear. So let's say you want to know whether drug A or placebo works for a particular patient. Let's say for me. Okay, so what I might do for asthma, and what I might do is I'll be randomized something. I'll take it. I don't know whether it's drug or placebo, and then I'll see whether my asthma is better or not. Then in the second period, I'll get randomized to something else. It may be the same drug or it may be the other one, okay? And I see whether I'm better. And then I do that multiple times, and in the end, we unblind, and we say, oh, see, every time you were on the drug, actually your asthma symptoms were better. You see what I'm saying? So it's a randomization within the individual, and at the end, it tells me whether the drug worked for me, okay? We don't do this in medicine. We do this very ad hoc. I asked them, well, did it help? No, well, let's try for another week and another month, and give me a call, tell me whether it works or not. Okay, very informal because we don't have the infrastructure for doing this in a formal, scalable way. Okay, very interesting approach. The issues of all of this is that right now the way we think about evidence is this something to be extracted, right? You go to the doc, you look at the care system, you look at the data, and you find out whether it works, okay? And in some sense, if you don't do it with care to how people are actually living their lives, to me it's kind of like strip mining. It's going in there and like ripping out the evidence, okay? And another way to think about it is this notion of evidence farming, which a colleague of mine, Rich Kravitz, is thinking about, which is where you think more organically and more sustainably about what you're planting. You're planting experiments that grow the evidence that is meaningful to you in a much smaller scale than, evidence strip mining for populations, okay? Much more personal, much more local, much more sustainable, and should be faster, okay? So in this one, if you go for data mining, this is stretching the analogy a little bit. It's kind of like rooting for evidence, going for the truffles, right? RCTs are then the industrial evidence farming, but kind of like organic evidence farming, if you want to think about it. But the N of 1 studies are like personal evidence gardens. So I want you to think about how can you build your apps so that they are like personal evidence gardens. So whoever's using your app, so let me use LogFrog as an example, okay? So I can know, because I have an evidence garden with, my frog. It's a good, your frog's in the garden. That you generate evidence that because of the way the experiments are structured and the analysis is structured, that I'm pretty confident that what I'm doing over time is really lowering my A1C. That's a pretty easy one, just because you can see the trends. But maybe your A1C goes up and down. And maybe there are things going on in your life. I was really stressed these 3 months, and so my A1C wasn't really down, but maybe it would have been really up, and those kinds of things, right? So how do I adjust for it? How do I really get strong evidence that it's working for me? Okay, not for everybody, but for me. Okay, so it's a slightly different notion. Maybe we can crowdsource exposures. Maybe if I'm looking at inflammatory bowel disease, maybe I want to find out from other people what triggers their IBD, and maybe I should track that for me. Okay. Outcomes. So maybe I should be tracking the same outcomes that everybody else is, so that we can, put all our studies together. Okay, and there are banks of instruments called PROMISE that the NIH has funded. A validated instrument for depression, the M3. Validated instruments for asthma. You guys are working in disease domains that clinicians have been working on for a long time. We have validated measures. And why don't we all use those same measures so that in the end we can all say something about whether we're improving disease or not? Right now it's very hard for anyone to do that. Why don't we share those measures and those libraries? Let's test and develop new instruments as a community. Okay, so that if we're asking for asthma, a tool that tracks your asthma status meant to be reported every 3 months is not the same instrument as one you would use, every day, right? It's a different instrument. So maybe we can work on that together. So we need an evidence macro system is what we need, right? Where we support all different kinds of evidence. And we do it in a way that feeds back on itself. And where each company, each app can extract from it, what's working for their individual patients, but we also learn as a whole system. Now the question is, how do we scale this, okay? And this quote is from another IOM report. It was a committee that I sat on looking at health IT. And basically we said this was in 2008. So this was before the stimulus package came out, before the $19 billion for electronic health records. And we basically said, look, the way that we're doing things in health IT isn't working. And if we keep doing the same thing, it may even set back the cause. Okay? This got us into trouble because we were kind of a little blunt about it. The health IT companies did not like this statement. But I think it's really true. If we keep doing what we did before, we're not going to get there. We're not going to get there. And you might say, okay, so fine, but what's the diagnosis? So that'll get us to the plateau of diminished returns. What is the problem? So our healthcare system, it's usage analytics. Okay, why do we all need to build the same ones over and over again? That's pretty low level. We should have an open implementation of that stuff. You can have proprietary ones too, but why not have a library of open ones that people can use, okay, with clean APIs that you can just call, okay? We obviously need to share data. That one's very hard, but very important, okay? How about informed consent, randomization, okay? All these approaches for N of 1 studies. Why can't all of those be done in a component fashion that you can just pull off and incorporate in your own products? You don't need to know all this stuff about clinical research. You should be able to borrow it, right, in ways that make sense in the context of your app. If there are ways to support patients to individualize their own N of 1 studies, you shouldn't have to build that. And sharing discovery, social media discovery of exposures, shared libraries, all those things we can build together, okay? And we're in the process right now of defining what that narrow waist should be, and catalyzing the transition of mobile health from sort of a stovepipe approach to this narrow waist hourglass approach. It's very different. It's not something you see in enterprise health IT. We didn't want to do this in health IT on the enterprise side because there are just too many entrenched players. I think mHealth is pretty open. This is the place to do it. Right now we have just gotten funding from RWJ. We're waiting for funding from California Healthcare Foundation. We're going to be a new 501c3. The code right now, there is no code. What our approach is to work with people who are already in the space, who have had enough experience to say what they would want to share and what they would not want to share, and also what's missing, what they would want out there that they would want to contribute to or borrow. Okay, so these are some of the partners that we're working with. We're about to decide what that shared code base ought to be. Okay, now that we have money, that will make it a little easier to do. Go right to this. This is kind of a functional diagram. You can see that we, in terms of the functionality for what the open architecture needs to support, it needs to support data collection, data store, and what I have up here in this box is really what we have heard from people is missing the most. I'd like to hear from you what's missing. It's data analysis, okay, time series summarization, summary statistics, trend and anomaly, noise reduction, the fact that how do you really pull data out of a GPS stream that's really useful, okay? And why don't we just have libraries to do that as opposed to doing it all ourselves, okay? Data presentation, huge issue for patients, for clinicians and patients working together. What's the workflow like? What is the UI? What does that need to look like? And then on the right, a box for systematic learning. How do we share variables? How do we share evaluation approaches? How do we build this evidence system so that we can learn both individually and together? Right now, we're focusing, our initial bunch of money is going to be focused on the stuff in the purple, looking at analysis and data presentation, because that's the guts of what we need. All the stuff about data store, mobile data collection, import, export to EHRs, there are loads of people working on that, and just, pulling that into a common infrastructure to us didn't seem like the biggest win. It seemed to us that the biggest win was to do something shared and open for analysis, presentation, and then the systematic learning, because that seemed to be the area where the greatest innovation and benefit could happen. So that's kind of where we are now. In the end, we want to be a learning community where there's both proprietary and nonprofit partners that are all working together, you know, so that health improves in a way that's measurable, and that we can feedback on each other. So there's contact information here. I'll be happy to share the slides, you know, with Hallie and the rest of you. But I, you know, would want some feedback on this, whether there's interest from any of you. You know, the timeline probably doesn't quite work for you, and we're still early on in our strategy about how we work with different groups, and are we doing the right thing? You know, is this something that would help the sector overall? But you know, we think there's some really great opportunities, and also love to hear what you're doing and just have a chat.
What is the timeline?